Good afternoon, everyone. Thank you, AIOC2023 and Dr. Ahmed sir, for giving this opportunity. Today I am going to talk about minimum invasive glaucoma surgery in Indian perspective. As all we know, we start the glaucoma treatment as usually the medical and laser treatment, then proceed for the primary for surgery like tube and trabeculectomy. But there is a wide gap between the safety profile like medical and laser to the surgery. So here the MIGS come and play the role. MIGS is the gap between the laser therapy versus the surgery. So if you look at the current trend, the MIGS is going to be probably the next area. The MIGS will be the first choice of surgery. Why MIGS is going to be popular? Because it's safety profile, less traumatic, and connecting the anti-chamber direct to the outer rectal chamber. So these are the various device-based MIGS are available. We talk about the India, only few device-based MIGS are available like iStent. When we come to the TM-based MIGS like GAT, BANG, and trabeculectomy is easily, readily available in India. So we look for this economy, really the iStent and ADB really not cost effective for a country like India. So these are the some MIGS like GAT, microtrabeculectomy, BANG, ADB are easily, readily we can do. So these are the various surgery easily we can perform in India, and it really have the little learning curve. So before starting any kind of MIGS, one surgeon has to be incompetent in the good intraocular gonioscopy. That's the first thing you have to learn, and it doesn't require much thing. Just you need the right gonioscope and that your microscope should do it. And never any time you have to learn, you have to try first. If you want to learn intraocular gonioscopy, then you start your any kind of surgery. So first I will come to the gonioscopic assisted transluminant trabeculectomy, Scott and GAT. This is 2014, first started by the Glaucoma and Fallman et al. In this procedure, originally the canal has been fed by the microcatheter. Later on, they changed to the fibroprolene suture. So what the indication? These are the common indications for any kind of MIGS. The primary opening glaucoma, mild to moderate stage without cataract, and even the secondary glaucoma you can do in the all stage. Until this is not the vision threatening, visual field having the vision threatening things. So these are the instruments required for the GAT. You need fibroprolene suture, microtine forceps, low temperature pottery. Rest everything is routinely available in our OR. So the video is showing how to perform the GAT. So first of all, we have to learn, this is the instrument we talk about, in positioning of the microscope. So we have to tilt your microscope 35 degrees toward yourself and keep the patient head away from you 35 degrees. So this is the perfect position to look for the angle, direct visualization of the angle. Then put the viscoelastic and dock the lens. Once we dock the lens, we can have the beautiful image of the angles. And here we put it magnified. In GAT process, we are just blunting the tip with low temperature cautery and form that AC with cohesive viscoelastic, and again look the angle. And this is straight determined with the goniotomy. A goniotomy you can do with MBR knife or you can do with 25 gauge needle. And this goniotomy side, just we have to thread suture, and really we need the 18 to 20 strokes are required to get the distal end. Once you see the distal end, just if you grab the distal end and this proximal end here to go, you can take it out. So another this is single case, another the second case with the silconoid. So clear the silconoid first, make the fibroprolene proline tip bend and make a goniotomy. Sometimes you get the unexpected reflex, you just clear it and again proceed the same. So I'm going to this another video. Recently we have started with the GAT into the PACG cases also. So this is to keep in mind. Once you master the POAG cases, then only jump into the PACG cases, because identifying angle is a little challenging with the PACG cases. So once you identify the correct angle position, you can easily perform the GAT in PACG cases. So this is, but there's a little difference will be there because here the resistance will be more in compared to the POAG cases. And really sometimes you feel at the end when it stroke, it's 50, sometimes 20 to 22 strokes are required. Really you feel resistance when the distal end is coming. And really if you feel distant, then you can understand it's in your correct position. And see that now the distal end has been came out. So similar way, just you have to pull it out. Once you pull out, there's a lot of reflex will be there. You need to clear the blood reflex viscoelastic and keep your chamber little bit tighter while you are closing the anterior chamber and wash it thoroughly. There should be no blood at the end of the surgery. So now coming to the second thing is called quick dual plate. In this method, the plate is being used to introduce into the slant canal, and this device is flipped and stretch the trabecular muscle. So I am showing this video. It's a quick dual plate. Similar way, we just have to make the anterior chamber, and this is the animation in which the plate is going into the slant canal, stretching the trabecular muscle, cutting and stretching. It should be done 30 degrees from the right hand side. Similar way, other 30 degrees from the other side. So this is the way. And only things such instrument when you are doing the first time, you have the blade in hand. Sometimes the left hand should be well controlled because sometimes you just press the too much pressure applied into the by left hand because your lens is holding. Sometimes you get the corneal folds. So that has to be managed nicely. And sometimes we get when you're doing this procedure, your blades, you have to be able to see the blade under the trabecular muscle. That means you are not too much into the slant canal. You are not disturbing the inner tissue of the inner part of the slant canal. And once it's done, you can see nicely exposed posterior wall of the slant canal, and at the end of just clear the lens. So what we can do in India, like because screening is current 14,000, it's the company recommended one single use, but we can use up to the 4 times. We use up to the 4 times saying the good results are there. So how to make it? This is simple 25 gauge lens, right? I will show you the video. So 25 gauge tip, just tip initial part of the tip, you have to bend it. Similarly, here the only thing we have to take care because the little end is very sharp, so we have to take care. We should not surround. We should not damage the surrounding tissue. So take this needle, and the needle tip always should be in your eye. This should not go away from your eye because once you go, it can damage the iris down and behind the slant canal also. And sometimes you get this tissue has been come out, then you can clear by the microforce. You can clear it. Then coming to this is the right choice of procedure called the microtherapy. This is a Sinski kind of instrument, and by this instrument you can treat the more than 240 degrees of the angles. And this is a quite simple procedure. This instrument you can, after phacoemulsion, you take the instrument through the side board, and this side board you just cleavaging the trabecular muscle. Just cleavaging and opening you can see the nice opening of this trabecular muscle, the posterior wall of the muscle you can see nicely. And this procedure, we can do first complete the temporal side, then you sit into the temporal side, and you can sit the temporal side, you complete the nasal angle, and sit to the nasal side and complete the other side of the angle. So it's a quite good procedure. You can do in a different case scenario. I'm not showing it. Then coming to the finally the eye stent. So eye stent is wonderful stent. It is very small stent used in the eye. I think it's a large number of this eye stent is used in the eye. It's called the eye stent. It's making the right communication between the anterior chamber and the outer collector chamber. So we have the long history of the eye stent. It's using more than 15 years. We have different kind of eye stent inject, eye stent W, and the various like hanger study and not showing the good outcome over a period of 5 years. So this is just video. I just have showing you how to do the eye stent. So similar way, just lock the lens, see the angle. When you're doing the eye stent, you see always in the high mag, go the magnification up to 1 or 1.5 to identify this eye stent coming the preloaded in the probe. 2 eye stent will be there in eye stent, and just you have to go and push it to the trabecular muscle and push the button in the probe. The eye stent is delivered. This is a good sign when you get the blood reflex by putting the eye stent to be a perfectly correct position in the slant canal. When reflex comes, remove the reflex with this plastic, check it, and then proper position is there or not. Then go for the another side, just 30 degree away from 30 degree or at least 2 clock away from it. Put the second eye stent and just tap it. When you're tapping it, that means you're fixing it. It's a perfectly positioned in the eye. And really it is have shown good. The only problem this stent is the cost. It's a huge cost, costing around 95,000. So coming to the MIGS complication, they are infrequent and mostly are transient. Most common complication is a hypema and maybe the elevated IOP. And sometimes in the learning phase, we can have the decimal member detachment, and some of the bang kind of procedure, we can have the Bosch's anemia. So MIGS combined with cataract surgery provide the safe new option for the IOP reduction. MIGS will become the first surgical choice for glaucoma management, where the GDD and the trap can be reserved for the difficult or complicated cases. Thank you for patience listening.
Thank you, Dr. Maheshwari. Now, I call upon stage Dr. Amit Porwal. He will be talking about combined surgery, cataract plus trap.
There's a change in the sequence. Myself, Devin, and Ganesh, we have a parallel IC running out now. We have to go there. So, Trupti will be moderating the whole session. And I'm going to talk on combined surgery, cataract plus trap. No financial disclosure. So, combined surgery is also known as a triple procedure. What are the indications basically for this procedure? Patient with cataract and glaucoma. These patients who have failed to achieve target pressure by medication. So the indications is patients who are having cataract with glaucoma in which they failure to achieve target pressure by medications. There are issues related to compliance, adherence, and drug-induced side effects. They are borderline controlled IOP, disease progression, or advanced GOA despite maximum medical therapy. And even you have uncontrolled glaucoma but an urgent need to restore vision, or when two operations are not feasible. The advantages of combined procedure, we all know about it. It eliminates the need for two separate surgeries, it reduces the cost, it reduces the early post-operative IOP rise significantly. The significant improvement in the visual acuity and IOP, and is also decrease in the number of anti-glaucoma medications post-operatively. Coming to the technique, you have the single site and the twin site technique. Single site technique can be done through SICS trap or a phaco trap on the same site. Twin site is basically you do a trap superiorly and do a cataract surgery temporally. I would always advise a phaco trap to be done in twin site and never an SICS trap, because the amount of congenital dissection is too high. So we advise only phaco trap in a twin site surgery. Now coming to the two videos, I will be showing simultaneously both the videos. So after taking the superior rectus stay suture or a corneal stay suture, you always mark a congenital flap. If it's an SICS trap, I will mark it at 6.5 mm, and if it's a phaco trap, I mark it at 3.5 to 4 mm. Congenital flap is created in one go, and it is dissected subcongenitally as much posteriorly as possible so as to have a diffuse posterior flap. Identify the bleeder and cauterize only the bleeder. Never over cauterize the bleeder, because if you over cauterize the bleeder, then when you prepare the scleral flap, there will be shrinkage of the scleral flap. Again, if you want to put any antimetabolite, what I do is before I make the scleral flap, I place the antimetabolite. The concentration and the duration of exposure depends on the individual case-to-case basis. And now what I do is I give some subcutaneous injection of mitomycin before I start the procedure. So making the scleral flap is a very, you have to be very careful. You just lift the apex of this triangular flap, which I usually do a triangular flap. So just lift the apex of the triangular flap, pull it as much as possible in the air, and just touch the cutting edge of the 15 number blade at the junction. So you will get a uniform triangular flap. Again, as I said, as you mark the congenital flap, also make sure that you mark the scleral flap also. So once the scleral flap is made, then the procedure of cataract surgery remains the same, what you have been used to, whether it is SICS or phaco. So in SICS, there are two lateral horns, and then the entry, the side port, all the steps remain the same. In phaco, once you have made the scleral flap, you shift temporally, and then if it's a twin side procedure, you can do a single side also. In a twin side procedure, shift temporally, and then start your phaco procedure. Only thing which we keep in mind as a glaucoma surgeon, when we are doing this combined procedure, we should be preoperatively prepared to see the amount of pupillary dilatation which is expected when you put the patient for surgery. So you should always document it preoperatively when you examine the patient. What is the pupillary maximum size of the dilated pupil, whether it is 6 mm, 5 mm, 4 mm. So we should be prepared mentally to tackle these small pupil issues also. So in this case, I was using a Malugin ring. This was a case of complicated cataract, this secondary glaucoma. So in this Malugin ring was planned. So you can plan any pupil expansion device which you want. Again, the recommended technique is a slow motion phaco, which I recommend because I don't want a lot of pigment dispersion. I don't want a lot of turbulence into the anterior chamber. And you can use whatever preferred choice of your phaco technique, whether it's a direct chop, stop and chop, divide, whatever you are comfortable with. So the tackling the cataract part remains the same. Only modification is the steps of the surgery. Basically, in twin side, you move temporally. In the superior side, once you create the flap, then you have to proceed with the cataract surgery. Again, when you inject the IOL, you make sure that the IOL is into the capsular bag and place the IOL haptic at 3 and 9 o'clock. You should never place the IOL in the circus. If the dire consequences, I mean, basically, if an emergency arises when the support is not good, then you can place it, but always avoid it. Place in the capsular bag, because quite a few times we have seen the haptic coming out through the broad-based peripheral anatomy, which is done, and it is disturbing the cornea or the angle. Again, internal ostium preparation, I missed that part. Telling you all, internal ostium can be created with the help of a 11 number blade, or it can be created with the help of a vanas, or it can be held with the Kelly sponge or an MVR. I'll show you the videos of how to create this internal ostium with various instruments. So once the internal ostium is created and a broad-based peripheral anatomy is done, suturing is very, very important. What I used to do is a single intermittent apical suture of 10-0 Ethicon, and I used to put 2 releasable suture. So releasable suture is very important. Everybody should learn how to put the releasable suture. My technique, what I've learned is basically pass this suture into the clear cornea parallel to the limbus in front in the clear cornea. Then from the clear cornea perpendicular into the scleral flap, and then from the scleral flap into the intact sclera. A loop is created over the scleral flap. Take 4 throws and pass these throws over this loop. So it's like a shoelace pattern knot which is there. Similarly, I'm doing this in the other side. So the suture is passed into the clear cornea in front of the limbus, and then the sutures are tightened in. Releasable suture gives us a better control. You have a tight AC, and post-operatively you can release this releasable suture to titrate the amount of IOP reduction what you want. Conjunctival suturing is very, very important. You should always remember to take an anchoring bite at the limbus or the episcleral bite. Take interlocking sutures with 8-0 Vicryl. Why you should take the anchoring suture is because of the upper lid movement. You don't want the bleb to be retracted posteriorly. So you want the bleb to remain there only, so that you have a posterior diffuse flap. For this, you need to take the episcleral bite in the episcleral tissue or in the limbal tissue. So interlocking sutures are done. Once you have tightened on the right side, the left side, make the conjunctival flap taut and put the suture similarly. This tautness has to be there, because if this tautness is not there, there will be leak, and then you have to put a matrix suture between these two conjunctival sutures what you have put, so that the leakage is not there anteriorly. By doing this, following this technique, basically you will get a posterior diffuse flap. Hydrate the AC, reform the AC, and whatever exposed part of the residual sutures are there, you just rip it off and hydrate and see that the adequate flow is there, and you get a posterior diffuse flap. So another clipping which I wanted to show was to make the internal ostium. There are two clippings which are showing simultaneously. So you can see in one Kelly sponge is used. Kelly sponge, you can make an L-shaped opening or a mushroom shaped opening, whichever you are comfortable with. With our MVR at the blue-white junction, just make a stab incision, extend a bit, and then with the help of vanas, cut the 2 thorns, and then you get the internal ostium is prepared, and then you do a broad-based styroidectomy. So again, variations in the techniques are there. This is a normal SICS straight tunnel. Just make sure that you place it 2.5 to 3 millimeter posteriorly, and you can continue with this. Again, here also you can put 1 intermittent and 1 releasable suture, or you can do this with the MVR also, the preparation of the internal ostium. So there are slight variation in the technique. Everybody has their own modifications. So these are a few modifications which I wanted to tell you all about. So thank you. I think we'll take the next speaker, Ganesh. Part of the residual sutures are there. You just rip it off and hydrate and see that the adequate flow is there, and you get a posterior diffuse flap. So another clipping which I wanted to show was to make the internal ostium. There are two clippings which are showing simultaneously. So you can see in one Kelly sponge is used. Kelly sponge, you can make an L-shaped opening or a mushroom shaped opening, whichever you are comfortable with. With our MVR at the blue-white junction, just make a stab incision, extend a bit, and then with the help of vanas, cut the 2 thorns, and then you get the internal ostium is prepared, and then you do a broad-based styroidectomy. So again, variations in the techniques are there. This is a normal SICS straight tunnel. Just make sure that you place it 2.5 to 3 millimeter posteriorly, and you can continue with this. Again, here also you can put 1 intermittent and 1 releasable suture, or you can do this with the MVR also, the preparation of the internal ostium. So there are slight variation in the technique. Everybody has their own modifications. So these are a few modifications which I wanted to tell you all about. So thank you. I think we'll take the next speaker, Ganesh.
Speaking on complications of trabectectomy, hope to finish within the 8-minute duration I've been given. No, yeah. So before I begin, I'd like to thank AIOC Chairman Scientific Committee 2023 for giving me this opportunity. So managing complications, I would like to highlight this particular article by the Shankar Netralaya group, Dr. Ronnie George et al. And a very nice article came out in 2011, which still holds good water. I would suggest whoever is interested in the topic to go through this article. Most of the material in this presentation is from this, apart from my experience and our clinical work which we have done. So still a very nice article to speak to on complications of glaucoma surgery. Mainly I'll be touching on trabeculectomy and pre-operative and post-operative also. So what we have shifted now is subtenance anesthesia, but previously if you were practicing surgery, you would really go in for periorbital anesthesia or retroorbital anesthesia, and you have a lot of these complications, acute retroorbital hemorrhage, perforation of the globe. So all that has almost reduced now since we have shifted to subtenance anesthesia. That is what we prefer now. You can have a lot of series of conjunctival related problems, mainly related to tears and holes in the conjunctiva, and the consequences also can be serious. Sometimes they can cause a failure. So why they occur is mainly because of poor visualization and poor exposure of the field and poor instrumentation, poor quality of the handling of the tissue and their related surgeon factors, and poor quality of in situ mechanical errors. So management is important. You have to identify very quickly, and if it's a large area of trab, better to shift to a new site of surgery and direct repair that tear with a suture. All conjunctival leaks should be closed before the end of the surgery. Flap creation is again important. What we usually teach is that the bevel of the 15 number blade is about 1 millimeter. So if sclera is also 1 millimeter. So if your blade goes halfway through the sclera for creating a groove, whether it is for small incision or for glaucoma, for creating a flap, you are in the correct plane. So that's something you can think of. And if you have a flap tear, it's very difficult to repair. You have to take the tear into the bite of the suture. And if you have a flap amputation, you have to be ready with a donor scleral patch cut for covering that area. Large scleral distance, again, you have to suture that area and then proceed to the surgery. And if you have large flaps, they usually produce a diffuse blips. Intraoperative bleeding, you can have conjunctival, scleral bleeding, or intraocular bleeding. And again, conjunctival bleedings are transient, mainly because the patient is hypertensive. That's the most common comorbid condition which we come across. And they will hamper, later on they will hamper the suture lysis. Scleral bleeding, again, if you have it, you better keep a direct pressure with a cotton tip applicator, or you can even apply on table, you can apply brimonidine, which will constrict the vessels and reduce the bleeding. Intraocular bleeding can happen from the major arterial circle of the iris. So you have to increase the intraocular pressure to prevent it and then close the flap very quickly, and then thereby raising the stopping the bleeding. And if you have large IPMA, then you naturally have to evacuate it using a paracentesis. Supraocular hemorrhage is a very important aspect. Risk factors include aphakia, vector mastitis, congenital glaucoma, pathological myopia, anticoagulant use, significant hypotony, prolonged hypotony during surgery, high baseline IOP, longer axial length, and prevention is by reducing the IOP before proceeding with the surgery by mannitol or gentle paracentesis, pre-placed sutures to prevent hypotony, and also you can use anterior sclerotomy as a preventive measure. So identification is very important, and shadowing of the AC, loss of the red glow, onset of pain despite adequate anesthesia, appearance of a dark posterior segment mass, and management. Scleral flap should be closed immediately, intravenous mannitol should be administered immediately, and in select cases you can do an immediate sclerotomy, which are actually very beneficial. Per-operative surgical will consider topical, peripheral, or subtenance anesthesia. So avoid retroorbital anesthesia. Never use tooth forceps. Aim for watertight conjunctival closure. Lower pre-op high IOP, and never leave the operating room with an unclosed leak from the conjunctiva. Post-operative complications, we know traditionally they have been divided into high IOP with deep AC, high IOP with shallow AC, low IOP with shallow AC and low bleb, low IOP, shallow AC and diffuse bleb. So tight wound closure can be the cause of a high IOP with deep chamber. So you have to start losing suture lysis early. And if you do that, again, you have a paradoxical shallowing of the chamber because of overfiltering. And these blebs have a tendency to fail also, so you can plan bleb needling. Tenensis is nothing but the exteriorization of the anterior chamber, so it usually happens by 4th week. You have a tense, tight appearing bleb, and bleb is formed, no microcyst. And the permanent solution actually is to excise the cyst and revise the bleb. Shallow chamber with high IOP, you can have 3 complications, which are pupillary block, malignant glaucoma, supracorneal hemorrhage. Pupillary block is usually the first differential diagnosis with a central appearing deep chamber, and posterior pigmental layer will be intact, supposing your iridotomy has not been complete. Avoid using the other problem is you may not have used sufficient steroid in the post-operative period. Because of inflammation, the PI would have got blocked, and it responds well to iridotomy. If you have the posterior pigment layer intact, you just do a small AIOC to it and it will open up. Malignant glaucoma is an important complication with a shallow chamber and raised IOP. The main predisposing factor is anterior chamber angle closure disease without a PI. So supposing you're operating in a patient with angle closure disease, don't have a PI, and sudden shalling of the chamber has a tendency to precipitate malignant glaucoma. So patient is usually asymptomatic, mild discomfort to severe pain. He may have the IOP may be normal or elevated, and the chamber can be anything from really flat to shallow and slightly deeper. And fundus examination, you can show aqueous pockets in high gain settings, and you will have to do a patent iridotomy to make sure that you are treating a malignant glaucoma. The important thing is that if you use atropine in these eyes, they respond to the condition. That means the condition responds to atropine. So the chamber will deepen, the refractive error will reduce, patient will be more comfortable, intraocular pressure will drop. So that shows you are actually treating a patient with malignant glaucoma. And the definitive treatment is to make the eye unicameral. So we had, I think, a talk yesterday or a free paper yesterday in which they did a iridotomy using laser, I suppose, but we prefer to do a full vitrectomy and make a communication between the posterior chamber and the anterior chamber and the posterior vitreous cavity. So that makes the eye very unicameral, and fellow eye may also develop the same thing, so you have to be very, very careful. Supraocular hemorrhage has been, the incidence has been mentioned 2 to 7%. And the risk factors I already mentioned. It's hemorrhage into the supraocular, into the choroidal space. You have pain, congested eye, reduced vision. You have large choroidal detachments, and you have blood in the supraocular space. Coming to congenital buttonholes. So risk factors: prior ocular surgery, poor tissue handling. The recognition is very, very important. And these are the main sites where you can have buttonholes in the, for example, limbus-based ribs. And the way to manage them is to apply a figure of 8 suture so that it's opposed very well. And if you have it at the limbus, you can just bring the congenital forward and suture it over the cornea. Or you can also use a purse string suture. Sorry. You can also use a purse string suture. Mitomycin C removal is very important. You should make sure that sponges, if you are using, they don't come out piecemeal. They should be removed in one go, and bits and pieces should not be left behind. If you happen to leave something like this behind, you may have a buttonhole like this. This is a mitomycin C sponge which was latent. Thankfully, it did not cause any complication except for a congenital defect. Scleral dehiscence, again, the risk of wound leak, shallow chamber is quite high. Risk factors include, like I mentioned, prior ocular surgery, thin sclera, and management is approximation using non-cutting needles. You can use a donor scleral autologous graft. So in initial, the management of supraocular hemorrhage is initial conservative, but you will have to drain them. The indication of drainage is if you have 360 degrees CD with RD, kissing CD, vitreous incarceration, vitreoretinal adhesions. And then low IOP with flat blebs, these are the numerous causes. You always paint the bleb to see the defect. If you have overfiltering bleb, you can use torpedo bandage. You can also, if you find there's a suture leak line, for example, like this, then you have to bring the congenital forward and oppose it. So be careful with many of these complications. They have a tendency to occur in the other eye also. So if you have a complication in this eye, always anticipate the same complication in the other. This gentleman had the same complication in both the eyes, operated about 9 months apart. So I'll stop here since my time is over. Any questions, we'll be happy to take. Thank you.
Questions to Ganesh? I'm sorry I was late, but I'm understanding that this is about related glaucoma also you mentioned. So I have a question. What are the signs that you know that you're facing an intraoperative malignant glaucoma, and is there something you can do on the table to prevent that and to make your case go?
Yeah, so for malignant glaucoma, usually we have the smaller when we're doing cataract surgery. That's one. If you're operating a glaucoma patient, in a combined procedure, you have a tendency to have that. In congenital glaucomas, you have a tendency to have that. So what happens is the intraocular pressure really becomes very high. and the chamber very collapses. You may not see the diffuse flow as in supracoronary hemorrhage. You may not see a diffuse flow as in supracoronary hemorrhage. That doesn't happen. So what you are actually happening is a transient raise in intraocular pressure. So three conditions we face that. If you are operating, for example, a pseudo-exfoliation glaucoma patient and you are doing combined procedure by doing cataract surgery, you can face that. When you are suturing, you can face that. When you are made the ostium and everything hits the roof, then you can face that. So what we do is we suture very fast. And the best thing for malignant glaucoma is atropinization. The moment you put atropine, close the section, put atropine, everything reverses. Next day you will find that everything's normal. You never face this problem. It doesn't continue. So like I said, atropine helps you to not only treat it actually, it even the condition responds to atropine. So close very fast and give atropine. So that reverses. What I feel, I don't exactly know, but I've had this in cataract surgery, I have this in glaucoma surgery, had it in trab. So the moment I feel that in cataract, of course I don't put atropine, but in all glaucoma procedures, if I'm doing implant surgery also, I face malignant glaucoma, I will give atropine as quickly as possible.
What are your thoughts about the panel's thoughts about intraoperative AIOC2023 to be able to proceed with the case? Because so why I'm saying this because I did it to one of the cases
right.
and I just
All of
want
us.
validation that was that the right thing to do. Would I do the same thing when I
So Arkesa, if you see Arkesa surgery or if you have observed his surgery or been his OR, he'll put a needle through the iridotomy, through the zonules and aspirate the vitreous. And that's okay, you could do that. If you have a good retina support, somebody can come and have a look and say that everything's okay, good. In a fake eye, it's very, very difficult. In a pseudo-fake eye, it's possible. You could do that. I don't prefer to do that. That's really quite risky. We don't know how far the needle has gone in. But yes, it is an option for emergency purposes.
For me, what I do is like I put a stage switcher.
Yesterday, there was a free paper on what you are saying.
Correct, yeah.
Dr. Siddharth Dixit had
He
presented
presented, yeah,
on 7 and he said it worked beautifully and he was vouching for it. He said if he could do it, it's not very difficult. We are taught that as soon as this happens, close the eye.
Close, yeah.
Close the eye, don't venture, give mannitol. But he said he used vitrectomy, he did it and all 7 cases said.
Yeah.
So you could talk to him through the iridectomy.
To the iridotomy, you could do that.
Iris,
but I've only encountered
He-
one case so far.
yeah, he's talked about 7. So you could talk to him.
Most of these eyes, if you see, most of these eyes will be angle closure, which has been missed, and PA may not have been done. So that's the whole gist of it. If you enter a chamber in an angle closure disease without a PA, very high chance of having this complication. If you do PA, let it settle, operate a few weeks or months later, then this doesn't happen.
I also want to add that we put stage switches while doing the surgery. So putting the stage switcher helps a lot. At the end, you just have to cut and place the IOL or whatever it is. Stage switcher supports you a lot, and mentally also will be much more in a good position to do the surgery because all these angle closure disease would have had a IOP for a long time. So we don't know what will happen next. Sometimes we have to extend it. So stage switcher helps a lot.
One more thing you just help me is keep the AC formed no matter what.
Yeah.
So before making the ostium, put viscoelastic
Correct.
air so that when you make the ostium, there is no sudden decrease.
Sudden decrease.
So that's one thing which has helped.
And too much of viscoelastics also might sometimes push the iris up. So the mannitol, giving the intravenous mannitol 1 hour before the surgery, that we do as a routine. That's 1 hour before the surgery, so that everything will be proper and well placed.
Should not also forget about post-op massage. That also plays very important role. Using the pinky post-op.
Maybe post-op also do the PI, you can do a gap,
Usually, if you don't cut the vitreous properly, it will reoccur. And how do you find that it is reoccurring is, first of all, you would have stopped the atropine, number 1. Number 2, the refraction will start getting myope. So moment the patient who's left emetropic starts getting with minus 0.75, 0.5, and then comes to -1, that means the malignant glaucoma is slowly recurring. So what we do is, we close the case and we do a full anterior vitrectomy posteriorly. We don't leave any vitreous, and then through that we do a complete We have a separate package for this in our institute. Some places they don't have that. What they do is, because administrative reason, they charge the full vitrectomy package for this procedure. Because we face this common problem quite commonly. We allow the vitreous, and most malignant glaucoma patients, if you take the history, they would have gone in for many times. They would have gone in for corneal decompensation later, because any anterior approach takes a lot of risk for malignant glaucoma. Turbulence is so high, you have very high risk of corneal decompensation.
And our VR surgeon group, they say that less manipulation will be better for them. So they tell us place the IOL in the surface close.
Close, we'll take care of it. So they have a separate package for the moment you label it as malignant glaucoma and antivitrectomy, it goes into a 13,000 rupees package rather than a 38,000 rupees package.
Thank you, sir, for
Thank
this
you.
excellent talk. Now I will call upon stage next speaker, Dr. Saiman, who will be talking about principles of initiating medical therapy in glaucoma, first line, second line, including AGM in pregnancy and in children.
Medical therapy in glaucoma. I have been allotted 10 minutes, though I'll try and sum up in 7 minutes. I can't hold people's attention beyond that in a topic like this. But just in case I overshoot, I was given 10 minutes. Anyway, so what is the most important factor which will influence your choice of medication is a question one needs to ask oneself. Is it how effectively the IOP will drop with a certain medication? Is it fewer side effects? Is it the cost? Is it the flat diurnal curve that you're noticing with the drop? Well, now the new standard in glaucoma care is only and only preservation of visual field. So irrespective of what your intraocular pressure level might be, as long as the visual fields are stable, the drug is working for the patient. And the goal of treatment now is to maintain patients' visual function and the related quality of life at a sustainable cost, being more and more patient-oriented. And your decision to treat will affect those not the ones who will do well no matter what you do, which are glaucoma suspects, ocular hypertensives, really old terminally ill patients. Not even in those who will do poorly no matter what you do, like bad glaucomas, neovascular glaucomas, or failed traps who will eventually do need surgical interventions. But those whose long-term outcomes will depend on your management choices. Formulating a target IOP is extremely important. Certain principles to remember here are that you keep a lower target IOP if you see an advanced glaucoma presentation, if you see additional risk factors like family history of glaucoma, fellow eye being blind, or disc hemorrhage, pseudoexfoliation, higher baseline IOP, and so on and so forth. And also, if the untreated IOP is low, you want to keep an even lower target IOP. The rate of progression, if it's fast, you want to keep a low target IOP, and also if the life expectancy is long, these are young patients. And but at the same time, it's also important to not be very aggressive in specifically two situations. One, when you have a glaucoma suspect or an ocular hypertensive, one very good handy tool is the OHTS glaucoma 5-year risk estimator, which tells you what is the patient's risk in the current scenario to develop POAG at the end of 5 years. So this is a very helpful tool for yourself, for your clinical judgment, as well as discussing with the patient, see, this is the amount of risk we are putting you into. Are you okay with it or not? So that brings transparency. And also the American Geriatric Society recommends that if a patient is too old, if in a chronic disease, only if the patient will benefit from your treatment, please put them under that headache. Otherwise, if the patient is not going to develop symptoms in his lifetime, leave him alone. Always before starting therapy, obtain several IOP readings. A diurnal variation test is a must. There is usually no need to start treatment unless all baseline diagnostic tests are collected, unless of course the IOP is very high or this is a very advanced glaucoma. And always grade the severity of glaucoma. Why that's important is, again, to formulate your target IOP. Now very broadly, these are not specific thumb rules, but in early glaucoma, you can keep a mid to high teen target IOP range. In moderate glaucoma, again, mid-teens, and in severe glaucoma, low teens. And in choosing your appropriate medication, please be very careful that compliance is an issue.
Keep the medication as cost effective as possible and minimum dosage. This is a very interesting video that I just added 2 days before coming here. Now this is how bothered the patients get, because these are old patients. Now this is the son who's flown all the way down from US to get the patient operated, and it's so confusing to give them long regimens like this. So keep the treatment simple and so that the patient can be more compliant. And also, this is no take-home messages from this slide. This is just a fun fact that I came across while doing my literature search. This was a paper published in AIO in 2002, which says there are 56,000 ways to treat glaucoma. Well, to simplify it further, the rule of thumb will be for mild cases, bring about 20% reduction, making sure that the visual fields are stable at that. For moderate, 30%, and for severe, 40%. Usually, we start with monotherapy, unless, of course, the IOP is extremely high and the glaucoma is advanced. We have several classes of anti-glaucoma medications, and meta-analysis of RCTs say that prostaglandin analogs are the most effective. In that order, it is bimatoprost, travoprost, and lacnoprost. Following this is timolol and brimonidine, betaxolol, and then carbonic anhydrase inhibitors. Usually, our first line of choice unanimously would be prostaglandin analogs. For multiple reasons, it brings about 25 to 35% reduction, which is more than any other class of AGM. It also brings about a better IOP diurnal control. There is once a day daily dosage, which improves compliance. There is lack of systemic side effects, and you also have preservative-free drops available. Although less than 10% of PG analog patients could be non-responders, they can be tried to be switched to other class of PG analogs. They could respond to it. And within the same class, the difference in the different components of PG analogs only brings about, in practice, not more than 1 millimeter or 2 millimeter of difference between the two. If you want about 20% reduction, beta blockers can do that for you. Also, make sure that you take a history of patient being on systemic beta blockers, because that can bring down the efficacy. We know the dosage of all the drops, and also it's extremely important to discuss the side effects with the patient, like how we say a glaucoma patient doesn't have a disease unless they've started on anti-glaucoma medication. That's when they start having problems. So discuss with the patient, teach the patient punctal occlusion, and also when monotherapy is being given to a patient when on PG analogs, please discuss with them the cosmetic problems they might face. Now, if a reduction of more than 40% is expected, combination therapy is the only way to go, because no single drop can bring about that huge reduction in pressure. But never start with a combination therapy except if it is advanced or very high IOP. Keep lower threshold for incremental therapy. And polydrug regimens or combination therapy actually is better in also many ways, like it improves adherence, cost is low, less preservative exposure, also washout effect of earlier drops is minimum. We have various fixed dose combinations available in the market. Now let's look at this one case very quickly. The baseline pressure for this POAG patient is 23-24. He is on PG analog, and over the last 4 years, his pressure right now is 17-18. And these are the fields which have progressed over over 4 years. And you can see this is a central scotoma threatening fixation, so it's advanced glaucoma for all clinical purposes. In the left eye also you can see a deterioration. So this patient responded well to initial therapy, but we still find that the visual field is progressing. So what are the options apart from this? Now we can either switch the PGA to a combination therapy. You can continue the PGA and use a beta blocker in the morning, or you can add a combination therapy along with a PG analog. But if you only add a single drop to a prostaglandin analog, you are not going to be able to achieve more than 3 to 4 millimeters of mercury drop in pressure. So when to switch? When your monotherapy is well tolerated, there is effective lowering of IOP, But the target IOP is not reached, you add another drop. But if your monotherapy itself is not working, it's not bringing about the amount of pressure that that drug is supposed to, you switch the monotherapy. Also, when you see that the progression is more in one eye, less than the other, don't give them confusing regimens. It's better to start the same drop in both eyes and keep it simple. So this patient was started on a fixed combination of PG analog, and he reached his target IOPs of low teens, which was important for the advanced glaucoma he had. And what to add? Preferably carbonic anhydrase inhibitors work very well when added to PG analogs because they have superior nocturnal IOP lowering, they have lower diurnal fluctuations and fewer side effects. The role of newer AGMs like nitarsodil, repasodil, and even latanoprostene do not. This is generally has value only as adjunctive therapy to the existing PGAs because they have different mechanism of actions. However, conjunctival hyperemia is of extreme concern, and also neither of these two classes of drugs have been tried in pregnancy or lactating women or even in a pediatric population. A few pointers over here: always explain to the patient how to put drops. Now this is a patient who had severe allergy to his drops because he's literally scraping the ocular surface with his eye drops. So there are various very funny demonstrations that you can see in your OPD if you see that a patient is not responding to therapy or having extreme side effects. So it's always good to ask them to show you how they're putting their drops. Also, choice of AGMs in pregnancy, very quickly, brimonidine is the safest. However, after 3 months, beta blockers and carbonic anhydrase inhibitors can be used. Do not use prostaglandin analogs because they induce uterine contractions. During lactation, PGAs are safe, carbonic anhydrase inhibitors are also safe, and beta blockers should be avoided. Brimonidine is absolutely contraindicated. And in pediatric population where medical therapy works, 86% of the times only is GOAGs and secondary glaucomas, and in congenital glaucomas when you're buying time to do the surgical intervention. Carbonic anhydrase inhibitors is the first line of treatment. Beta blockers also. Prostaglandin analogs can be tried as the second or third line of treatment. Thank you.
Thank you, Saiba. Are there any questions? Saiba, I wanted to ask you a question. What is your preferred combination when you want to switch combined therapy? Which combination you prefer, and when you consider them from surgery, like what you consider as a maximal medical therapy?
Ma'am, I feel after the patient is generally, theoretically speaking, after the patient is on 2 AGMs, rather than putting the patient on a third anti-glaucoma medication when you're only going to be able to achieve a more 5% more of reduction, I think the patient is bending towards surgery. And now with the introduction of MIGS surgery, I think that is the area where MIGS works really well. Of course, keeping in mind that this is not an advanced glaucoma or not very complicated glaucoma like secondary glaucomas. And as far as the combination therapy that I prefer over and above PG analogs that the patient is already on, I think I do a combination of carbonic anhydrase inhibitors and beta blocker if it is not contraindicated. Otherwise, I prefer brimonidine and brinzolamide.
Along with PG analogs?
Along with PG analogs. In the second case, wherein a beta blocker is contraindicated.
Is there any particular way you will tell them about the brimonidine eye drops, especially in pregnant women?
Oh yes, yes. All the contraindications have to be kept in mind, ma'am. Brimonidine.
When would you prefer to stop that eye drops? When you have given it in pregnancy?
Before 3 months.
3 months.
Yes, past organogenesis, brimonidine is not indicated.
Usually brimonidine, when we give in a pregnant patient, we usually stop 1 month prior to pregnancy because we don't want it to get secreted in the brain.
Correct.
In that time, you can also, it is safe to shift to the beta blockers.
Yes.
Okay.
Yes.
Which is a drug of choice in a patient with corneal compensation or corneal complication.
Corneal complication. I think the only beta blocker, the AGM that you have to avoid is carbonic anhydrase inhibitors, and of course, if the eye is inflamed, also PG analogs. The rest of the classes you can give. Thank you, ma'am.
Thank you, Dr.
A very good afternoon to you all. Thank you, All India Congress, for giving this opportunity to talking to you on pre and post operative considerations and trabeculectomy step by step. First and foremost, we have to ensure that the patient needs trabeculectomy. We have to explain to the patient the unpredictable nature of the post-op course of the disease in spite of the best surgery done, even that the patient may need daily post-op follow-ups, that he or she may need secondary surgeries, chances of long-term failure of the surgery, and involve the patient in the decision-making process and take a proper informed consent. So, we usually stop all anticoagulants about 5 days before surgery and pilocarpine 7 days before surgery. To stop prostaglandin analogs before surgery or not is the individual approach. Different surgeons do so. And if we require to stop it, we can stop it 7 days before surgery. In case of the fact that we should be prepared for very high IOP which still persists on the table, and we should be prepared to do a vitreous tap and take an informed consent beforehand for that. So another thing I want to emphasize is that you should take prior physician opinion before stopping anticoagulants, written, and injection mannitol if you have to give in case of the patient. And another thing is this: you should rule out GFR compromise, benign prostatic hypertrophy in the patients, because we had experience of one patient who had a timer was not changed, I believe, whatever. So the preoperative considerations include: do not take a retrovalvular, use a retrovalvular block, you do not use amlodipine in the block. We normally use mitomycin C, never use more than 4 days old preparation. And coming to the steps of the surgery. So the superior rectus bridle suture is to be passed deep into the muscle. On the other hand, corneal traction suture is also equally well serves the situation and gives a good exposure to the operative area. And this is followed by raising of the cornea space gingival flap. Ensure an even cut at the limbus. The advantage is easier handling, but the disadvantage is chances of an anterior edge leak. This is followed by the subconjunctival dissection. Avoid buttonholing, always sweep both sideways and posterior direction along both sides of the superior rectus muscle to ensure a posterior flow of the aqueous. A gentle but adequate cautery. Subconjunctival mitomycin C soap sponges are being used, thoroughly washed with BSS. Alternative is to inject mitomycin C 0.2 milligram per milliliter in the subconjunctival or subtenon space and spread it with the applicator. This is claimed to ensure even uptake in the conjunctiva of the drug. Sorry. Can you just fast forward this? It's moving on its own. Fast forward. What's not happening? Yes. So normally in the post-operative considerations, we do not take tension apprehension on the first day. Remember that IOP of up to 24 millimeters of mercury with good blood morphology and a proper iris diaphragm position can be safely observed for 3 to 4 weeks post-operatively without intervention. We should do gonioscopy post-operatively to rule out any stomal blockage. Usually we start at 2-hourly prednisolone acetate and gradually taper them, but it depends upon the clinical evaluation and the condition of the blood. We should be prepared for a shallow anterior chamber. We should not panic and intervene as a knee-jerk reaction, because even very shallow anterior chambers with peripheral iridocorneal touch without any lens corneal touch can resolve in 3 to 4 weeks time without any intervention required. So in some cases we need to do the bleb massage. You can see this video how it is done on the slit lamp with proper indentation of the inferior cornea, the gradual swelling of the bleb. The suture removal has also got to be planned, and it can be done in the slit lamp, as you can see in this video. After removal of the corneal embedded part of the suture, it is drawn properly along the axis. Laser suturolysis with the Hoskins lens, as shown in this video, is also possible if you have used fixed sutures to elevate blade function and better drainage of the control of the intraocular pressure. In some cases, we do need to go ahead with bleb needling. Corneal traction suture is taken about 10 mm away from the limbus. Insertion of the 36 gauge needle, go through the flap, go into the stoma, clear the stoma and the anterior chamber, and while coming out, you can sweep sideways to break fibrous adhesions to help in formation of the blade. Though does not serve your purpose in every case, but in some cases it can definitely be heard. Thank you.
Thank you, sir, for a wonderful talk. Due to lack of time, we will not able to take further questions. I call upon stage Dr. Preeti Paritosh Kamdar. She will be talking about glaucoma drainage device, AGB and RD flaps.
Slides.
Okay.
So I'll try to finish fast and not really take the full 8 minutes allocated. So 11 commandments. One is perivalvular anesthesia. Instrumentation. And when I was learning to do implants, it was, for me, the rate limiting step was how to expose something which is 10 mm behind the limbus. The anterior edge of the implant has to be 10 mm behind the limbus. So that was one rate limiting step for me. So that's why I put it exposure, exposure, exposure. Then you learn conjunctival dissection. These are the, if you break your surgical steps into these 11 things, it's a cakewalk for you. So now, what are the instrumentation apart from a cataract? Apart from what you use in a cataract, what do you use? So this is a Hoskins forceps which you use as an atraumatic forceps for every trabeculectomy or any glaucoma procedure where you handle the conjunctiva. Then this is the forceps. You don't use a normal wire forceps, but this one, and because it gives wider exposure. And this is one forceps called the ring forceps. It's actually a Fechner's forceps, but I call it a ring forceps because it's a very beautiful way of handling any conjunctiva or even the valve. This is a 30 gauge needle to prime, or a 30 gauge cannula which you may not have in your instrument set, and this is what you will require over and above your cataract set. So this is the procedure for an AGB. This is done for a traumatic glaucoma where there was vitreous in the superior part in iridodialysis, and because I'm doing it for a primary, it's a primary procedure which I'm doing. And as I said, that exposure was the rate limiting step. The corneal traction suture is the best way, and you roll it down, not pull it down, roll it down with your thumb, with the assistant's thumb, and it will be, the exposure is great. Now what you do is, you dissect the conjunctiva. It's easy because it's a primary surgery, and you dissect it, go deep behind and make a lateral conjunctival incision. Having done that, the exposure becomes better. You could do it on the other side also. Having done that, again go with a closed instrument, open so you don't traumatize. This is an important step where you prime the valve. If you don't prime the valve, it's not going to work. So after you ensure, this happens to me every single time that I do an implant. After the initial dissection, I put it in, it bounces back. It means I need to redissect. Now I am confirming that it's 10 millimeter. One tip is when I realize I'm not able to put it back, I decompress the eye. Once I decompress the eye, it stays in place. It doesn't bounce back. And now you suture it with 9-0 or 10-0. 9-0 works for me. And there are two eyelets, and you suture it properly, and it will stay position. Now I'm cauterizing, very little cautery, and here is where I have started doing things differently. I don't use a patch graft. I see no use for extra material inside the eye. So I'm making a very long scleral tunnel. I mean, if you're used to ICS, SICS, there is no problem with this. So do that. Now, as I said, there was vitreous. So in this particular case, I had to have a colleague, the retina colleague, do a vitrectomy, and there is the vitreous, cut the vitreous properly, and it was first stained obviously with triamcinolone. Particularly now superior part, make sure it's completely free of vitreous, and now I'm injecting viscoelastic into the scleral tunnel. Then I go with a 25 gauge needle and dip inside, parallel to the iris, more towards the iris. Now cut the tip, bevel up, and slightly try to slide the tube in. But it's difficult, and I have no access in the proximal part. So what I am doing is I am cutting the scleral tunnel so that from this end, now I can have access to the tube and direct it posteriorly. This is one modification I have made in my surgery. So now I have access to the tube. Otherwise, it becomes very difficult to direct it inside through a 25 gauge needle. Now here I have put it properly, and you are able to see the tip of the 2-3 millimeters inside the cornea. But now I decide that it's too long. Now I want to take it out, and you'll see how snugly it has fit inside. It won't move. It's difficult to take it out, and I had to make 2-3 tries. Now again, I'm re-trimming it, making sure that it is short, and then putting it back inside. This is the ring forceps. It's so atraumatic and so beautiful. It's helped me in my surgeries, trabeculectomy plus this. And now slowly put it inside. Make sure that the entire tube is in. And now you will suture the conjunctiva. The same suture, 80, which I used as corneal traction suture, I'm using it to suture the conjunctiva. This is a continuous stitch, and this is the wing suture. So this is cosmetically, it's more acceptable to the patient. If you see a scleral graft, it's really bad. I think we are short of time, so then I will, complications, hypotony, tube touch. I mean, it's a long list of complications, and it's beyond this was only to show how to do a good AGV. So complications, another lecture by itself. Hypotony, tube touch, exposure, large filtering plebs, and extraocular movement restriction are the complications with this. Hypotony and tube touch are the main ones, and exposure occurs a little later. So thank you for a very patient hearing.
Thank you all the presenters for excellent presentation. Sorry we will not able to take any question, and I request the next session can be taken over. Sorry for the delay.